So, I guess one of the main questions is where did intrinsic biomechanics, or this concept that you developed, where did it start? Where did it come from?
Well, a long time ago, probably 30 years ago now, we as physios were treating patients. And we were doing everything that we were trained to do. We were laying our hands on, we did a bit of exercise, and we got some people better, as a lot of therapists do. But we kind of got to a point where we're ringing patients up. We're ringing them up sort of 6 months after they've been discharged, and we were thinking that we'd fixed them all, of course. Being a sort of 18, 19-year-old male, thinking you've got to fix everybody. And then when we were ringing them up, we did the sort of post treatment follow up, and we found that probably 50% of the people that we were seeing, their problems had recurred. So we figured that what we were doing really wasn't adequate. It was for some people, but for a lot of people it wasn't adequate. So what we did is we started to look at what we thought might be the reasons. So we started to look firstly at the way people moved. So we were doing what are now commonplace, the sort of movement screens. We were doing the video analysis, and we were just trying to understand why people moved as they did. And what we found after a while is that we got really good at identifying the way people moved. But that did not tell us why they were moving like that. We kind of figured that the way people moved were causing the problems, or in some cases could have been causing the problems. But unless you identify why they're moving like that, it kind of doesn't help. We tend to find, and Sharman now has done a lot of work on this. This was sort of 30 years ago when nobody had done any work on it. People kind of fit into two categories with an injury. Either you get an injury, which or a pathology, which then changes the way you move, or the way you move causes an injury.
Right.
And what we found we were quite good at as therapists was, if there's a pathology or an injury causing an abnormality in the way you move, get rid of the pathology or injury, change the way you move. And we got quite good at that, and most therapists are. But what we weren't very good at was identifying the way people were moving and how that was causing the injury.
Right.
So we then spent a load of time trying to find out why they moved like they do, thinking that that was the right thing to do. And then when we'd done that, we then realised, well, but we still don't know why they're moving like that. So it was then that we started to develop what is now we call the Intrinsic Biomechanics program.
Interesting. So you said that you felt that we, or you as a group, were finding it difficult to analyse movement and understand where problems were coming from. Is that not FMS or functional movement screening, or a lot of the modern day concepts is to look at patterns? Is that a similar thing, do you think, or is that something different?
No, it is exactly the same.
Right.
And I think even with the modern systems, and there are a lot of systems out there, of course.
Yeah.
FMS is one, the performance matrix is another. There's a load,
Yeah.
and they're all similar. But principally what they're looking at is how people move.
Okay.
You then have to use your own expertise to identify why they move like that. And some people have that expertise and some people don't. So when we're developing the program, we figured that it would be a good idea to try and identify why they moved like they do, rather than just looking at the way they move. You see, the problem is, and we found this out the hard way, if the way they move is causing the injury, and then you change the way they move, you reduce the load on the injury, and that's fine. But if the way they move is a protective pattern because they've got an injury, changing the way they move is the worst thing you can do.
Right.
You often aggravate the problem. So you need to be able to identify which is which.
Yeah.
And ultimately, you need to then, if it's the second problem, if it's the injury causing the way they move, then the question you have to ask is, well, if we change the way they move, chances are it's going to aggravate the injury because they're moving the way they move to reduce the pressure on the injury. So what do? Do we treat the injury? Well, if you're a therapist, that's great. But if you're an exercise professional, you can't do that. So what do? So that's when we developed the program.
Right.
How can we create a system that enables people to objectively look at the key biomechanical features that are increasing the load on an injury, which then influences the way you move?
So it's imperative that exercise professionals and clinicians talk to each other.
Absolutely.
Because
absolutely.
it often I know as an exercise professional, my background's exercise, yours is more clinical. And one of the things was client or participant's expectation of me as an exercise professional. I've got a bad back or I've got a sore knee, as to how I could help on my advice. But obviously there's a risk that if there's a clinical issue there that I can't diagnose or I don't know anything about, I could be advising them poorly. So we're at risk of being of not being covered on an insurance level or creating more of a problem.
Yeah, absolutely. If it's a clinical problem that's causing their pain rather than a movement problem, then it has to be dealt with by a clinician, absolutely. And if you as an exercise professional started to change the way they move, and the way they move is a protective pattern for an injury, that could be a problem. So avoiding that is a pretty good idea. I think one of the key things that we teach on the Intrinsic Biomechanics courses is the ability to be able to identify the key biomechanical issues that both lead to injury and lead to abnormal patterns. And that's kind of safe, because ultimately you're neither dealing with the movement nor dealing with the injury. What you're doing is providing that individual with the capacity to be able to move what's natural to them, bearing in mind their clinical pathology and their other biomechanical problems. So it's the safest way of doing it.
Yeah. And it's also completely the opposite way around, in that it's joint by joint, it's isolating areas as well. Can you expand a bit on that, on why it's different?
Yeah, absolutely. The problem with a functional exercise program and a functional screen is that while you can identify whether the movement patterns are abnormal, whatever that is, what it doesn't allow you to do is to identify where the problems come from. And if, for example, you had a problem with the knee, whether it's a clinical problem or a mechanical problem or whatever it might be, you've got the hip and the foot that could easily compensate for that. That's what the body does. So you could pass a movement screen, irrespective of what type of screen it is, and still have key problems with one of the three hip, knee or ankle joints. So you need to break it down individually so that the ankle, the knee and the hip and the pelvis and the spine and so on are assessed and screened individually to make sure each individual layer has the capacity to perform normal movement, and then put it together as a coordinated, synchronized pattern of movement in a functional program. No problem at all, that's great. But if you try and do it the other way around, oftentimes if it's the knee that's the problem, for example, and you're doing a functional pattern, all you're doing is teaching them how to cheating them how to perform a movement extrinsically correctly, but intrinsically there's still problems going on.
Still a problem. So with that in mind, quite often where the problem, the poor movement or even the discomfort comes from is what you're saying, I would imagine, not where the dysfunction is, because it could be the joints above and below where the actual problem is, and the pain is in the other area.
Right, absolutely. Right? I think it was Carol Lewitt that said if the person that treats the site of pain is lost. And that's usually right. Okay, if somebody's post-surgery, of course, you have to treat the bit that they've operated on, of course. Outside of that, probably one of the last places you look is where they get the pain.
Which again, for exercise professionals, is safer because if that's where there's some tissue damage or something going on, we're not messing around and irritating them.
Absolutely.
So, when you did this research, it was quite extensive, as I understand. It was sort of 4,000 subjects. Who were they? What kind of people were you working with? Because I understand some were quite well-known people. Would you like to share any of those with us?
Yeah, I think it was basically anybody that came in for treatment. they got screened, whether they needed it or not. At that time, they got screened. We were dragging the cleaners in and screening them. We had no idea what we were doing, to be honest, or why we were doing it. So the work we did was definitely retrospective. We just screened a load of people and then looked back after that to try and identify the common patterns, the common issues, really. So we were looking after regular folks. We were looking after Olympic athletes. We looked after Daley Thompson, Linford Christie, Coe, Overt, these sort of people. Formula One, we used to look after Hakkinen and Coulthard. A load of boxers, gymnasts, professional football players. We looked after most of the guys most of the teams in the Premiership, as well as the England rugby team, Irish rugby team. So we looked after a few different people, really, which was fun.
So why did those people come to you? Did you have a reputation? Did you have something different or special? Because if it was retrospective, they didn't know they were coming for those skills.
Right, absolutely. I think, if I'm absolutely honest, because when we originally started, we didn't have any equipment or anything like this. We were regular Joes, so to speak, physio-wise. And it was when we started to realise that that wasn't really where we wanted to be, that we invested quite heavily in pieces of equipment to measure people. So we got ice kinetic machines, lumbar motion monitors. The ice kinetic machines were peripheral machines to measure muscle performance and joint performance for the periphery. We also got 2 huge pieces of equipment that measured trunk rotation strength and trunk flexion extension, I say strength, but output performance. You know, 30 years ago, we were the only people in Europe actually privately doing this outside universities. So, to be honest, I think it was the fancy kit that got these people there. And we were also, the video analysis, while crude by today's standards, we were videoing people running. We had 3 or 4 video cameras, and in those days we put it up on a TV screen, and we had protractors on the screen and drawing lines on the screen. It was really crude, but nobody else was doing it. And it was, again, that helped us put the intrinsic biomechanics piece together with the extrinsic, how people were moving, and started to piece it together. So that enabled us to create a philosophy, so to speak. And now when we get access to the kit, that's great, we use it, but when we don't, the screens and the exercises and everything that we do is based upon the old days and the work that we did then.
So I would imagine the beauty of that is with equipment or with the screens that you've developed is the ability to assess someone, give them an exercise, and then immediately reassess. Is that right?
Absolutely. And it was great because people would come in and say, I've got a knee pain. They said, right, okay. So we'd stick them on the ice kinetic machine, we'd do a load of testing on it, and if you've got a pathology within a joint, there's a reasonable chance that if it's causing a functional problem, the machine will pick it up. There'll be a strength deficit or a power deficit or whatever it might be. When the results would come back negative, you can show them a piece of paper to say, look, you may have knee pain, but this is like looking at a negative X-ray or negative MRI scan. There's nothing wrong with it. So it's something else. And immediately they'd buy into that. It's very simple to sell when you've got data to show that there's actually nothing wrong with that particular joint. Oh, okay. But then when we see you running on the treadmill, we can see that your foot's flattening or your hip's dropping or your arm's doing this particular movement. And then you do an intervention or an exercise or a treatment or whatever to change what you see. They see it changed on the machine, on the rescreen or the re-video, for example, in that example, and the pain goes away. It's a no-brainer to an individual that's receiving this sort of information.
But you don't actually need all the expensive equipment, which was, as I understand it, why you developed and tested and sort of the retrospective research into manual screens that do the job of the ice kinetic machines.
Right.
And isn't that quite a close correlation, is that right?
It is very close. Is it as good? No, of course it isn't. But it's very close.
Saves me a few £100,000.
Yeah, about 200 grand. It's close enough to be useful for sure. So the idea of needing all that equipment, you know, if you go to an amazing performance institute, they should have all that kit, and that's great. But if you don't, then the screenings and the principles and the processes that we've developed based on all that information gives you just as good results.
Yes, at 97% accurate to gold standard laboratory testing. Some of them are.
It's that sort of.
That's pretty good.
Yeah.
If you haven't got that cash.
Yeah. Yeah, I mean, there are flaws in manual screening, obviously,
sure,
reproducibility and validity and all that stuff, of course there is. But when you train properly and everyone's doing the same thing and you train to a high level, then it's pretty close.
Yeah, and that's something that we're passionate about at Biomechanics Education Limited. So what are you doing now? What's, in brief, in a nutshell, where have you got to now with regards to, I don't know, research, or who you're working with? What are your plans? I know you're consulting and you're out and about and going to Sweden and all sorts of places, right?
I'm trying to do as little as I can get away with, to be honest. Some of the stuff I can't go into too much detail about, but working for medical companies to look at how intrinsic biomechanics can impact upon implant design, knee implants, hip implants, that type of stuff. How the process and the principles that we've developed can help post-operatively, pre-operatively.
Right.
That's quite a huge project, as you can imagine. So we're hooking up with a number of universities all over the world, particularly Australia, the US and Sweden, to try and link together loads of individual pieces to look at how we can be more sophisticated, objective and consistent about how we're rehabbing people. So that's a huge project, and that's a lot of fun. Also working with a shoe manufacturer to look at how we can improve the biomechanical design of kids' shoes. So that's a lot of fun. But it's all down that sort of biomechanics principle stuff. Also doing quite a bit of medical legal work, because what we do is so objective compared to a number of other ways of doing things. The medical legal companies are now saying, well, how can you get involved in screening people post-car accident, for example? And it's all about objective outcomes these days. So how can we use your system to be able to develop programs to help people post-head injury, for example, which is completely different to the musculoskeletal stuff that I've been used to. So that's really interesting. Yeah, quite a bit of travelling, quite a bit of international lecturing still, which is fun. I quite enjoy writing, so I've just written a chapter for Science in Soccer, published by, I think it's Human Kinetics, and that comes out end of this year, I think it is. Yeah, just getting involved in as many different things as I can to try and look at ways of expanding the intrinsic biomechanics program. But I think one of the key things I'm interested in is design. I really like the design idea. I think I've got a really good team now, as you know, and I think the idea of creating new ranges of fitness equipment based on the intrinsic biomechanics model is a really interesting one. I've already mentioned the shoe idea. Got some ideas on golf club design, for example. I quite like the idea of designing another walking stick that is more relevant to how you're supposed to function. So there's loads of different things that I'd like to design and create. Because ultimately, when you're one person or a small team, you can only affect so many people. You can only help so many people. I know it sounds altruistic, but it's true. If you design a product or design a software program or you design something that is out there, it's infinitely scalable. You can help more people. And actually commercially it's more interesting. So yeah, so we're doing a lot of different stuff at the minute and do a little bit of teaching still.
Good. I need you. Anything different or any plans for the future, or is it just going more of the same of what you just talked about?
Yeah, more of the same really. I think really keen to get more involved in the research side of things, working with a number of universities to do that. But that's a slow process, so that's very much sort of down the line in terms of results and outcomes. I think really that the long-term future is being involved with teams, being involved with corporates, and kind of spreading the word of intrinsic biomechanics. And I think one of the values of that is that those people that sit your courses start to have a benefit in that people will start to know, the public will start to know what a biomechanics coach is, what intrinsic biomechanics is about. Because as I say, some of the projects I'm not able to go public on, but some of them I am. That will probably be a good thing for the people that are going through the courses.